Thanks, Jamie. Got it. All right, let me share my screen. So the great thing about this program is this is our first program of September, our first big program of September, and new statistics and data in healthcare come out in January and in August. So yesterday afternoon, I updated this program and really got excited about a lot of the things that I was finding and seeing with updated statistics. One of the things that we've been doing here, Jamie started this education program 12 years ago, is trying to educate the public about all of the dementias. So it's great to see that there is so much more information out there right now. I do want us to start with frontotemporal disorders and degeneration for us to understand this is one of just a couple of dementias that can present with no memory loss. You heard that right. A person can actually even get a diagnosis of FTD, a frontotemporal disorder or a frontotemporal dementia, and not have any memory loss yet. It will come later. We'll talk more about that. This is some more information about us here at the West Center. Excuse me, I have got my drink right here, but I am trying to cough today. I do not know why. We do provide residential care, respite care. We have our day program, and then we also offer short-term rehab. There's our objectives. And let's just start by a review of dementia, a short review of dementia, remembering that dementia itself, the word dementia is an umbrella term. Dementia itself is not the diagnosis. Dementia, the word dementia is just like the word cancer. It's an umbrella term. If someone were to say their loved one had cancer, we would then ask what kind or what type or what form of cancer. It's the same with dementia. What kind, what type, or what form of dementia. Now, what's interesting about FTD or frontotemporal dementia or frontotemporal degeneration is it really could have its own umbrella, as we'll find out today. Underneath that dementia umbrella, vascular could have its own umbrella. There's different types of vascular dementia, but the one we're talking about today, frontotemporal dementias, plural, could have its own umbrella. And you'll understand more about that within the hour. So let's look specifically at the definition of dementia from the National Institute on Aging. And this is a pretty new definition, the way that they are now wording it. And it's important to get the very last part of this. Dementia is the loss of cognitive functioning, thinking, remembering, and reasoning, and behavioral abilities to such an extent that it interferes with a person's daily life and activities. Dementia is so much more than memory loss. People will use the word dementia and memory loss like they're synonyms, that they mean the same thing. There's over 130 different types of dementia. There's over 30 symptoms to dementia. Memory loss is one. Now, those of us who work in the field are very thankful to this family that you see here. This is the Bruce Willis family. This is Bruce Willis. His family is taking his battle with FTD public. And boy, do we need more of that. Because when I find out something that I read last night, that someone like Bob Barker actually died with Alzheimer's disease, but they kept it hidden, it can make people feel like it's something to be ashamed of, or like it is something that we need to hide. And it isn't something that we need to hide. This didn't happen because of something that they did. This isn't something that we need to be so embarrassed about that we hide it from the public. And this family, thank goodness, just like Glenn Campbell's family, Sandra Day O'Connor's family, has come forward and is owning this disease. As a matter of fact, I put in bold, this is the statement from the Willis family, but I put in bold a bullet point, and I want you to hear what the Willis family had to say to the public. And they are working very closely with the Association of Frontotemporal Degeneration, the AFTD, and we'll talk more about them as we go on. FTD is a cruel disease that many of us have never heard of and can strike anyone. For people under 60, FTD is the most common form of dementia. New statistic. It used to be Alzheimer's disease, and FTD was number 2. Now, FTD is the most common form of dementia in people under 60. And because getting the diagnosis can take years, FTD is likely much more prevalent than we know. Today, there's no treatments for the disease, a reality that we hope can change in the years ahead. As Bruce's condition advances, we hope that any media attention can be focused on shining a light on this disease that needs far more awareness and research. And his family has been great about posting videos of him. His wife is posting her struggles. She's being very realistic about this disease. They give some information to the website, and then we will give that to you also. I've got an entire page of resources that we'll talk more about in just a little bit. But I wanted to share that because if you don't follow the Willis family on social media, I encourage you to do so. They're being real. So let's talk about frontotemporal disorders. And like I said, it is a group of disorders. It is not just one disorder. It's a group of disorders. And what's happening is a little bit different than what we see in some of the other dementias. What's going on with FTD, frontotemporal disorders or frontotemporal degeneration, is that there's a progressive nerve cell loss in the brain's frontal lobes, which is right behind the forehead, and or the temporal lobes, which is right behind the ears. So in this area here, we're going to talk about what all is controlled in that area. That's why we will start to see some challenging expressions a little earlier in people with FTD than we might in, say, Alzheimer's or vascular. Notice I use the word expressions rather than behaviors. Those of you who do our programs on a regular basis know we are trying very hard to switch from using that word behaviors because of that negative connotation that comes with it. They're doing the best they can with what remains. So the frontotemporal part of the brain begins to atrophy first. With the other dementias, as we are watching the disease progress, and we're going to look at a scan next, the brain tends to atrophy at a fairly even rate as it starts to shrink, going down from 3 pounds to eventually 1 pound. But in the person who has FTD, this frontal part of the brain starts to pull back and shrink first. So what do we see first? Many times it's personality changes. Well, who in the world, in somebody under the age of 60 who's having personality changes, is going to immediately think dementia? They get misdiagnosed all the time. And that's what the Willis family letter was saying. Because it takes so long to get a diagnosis because of the age of most people who develop FTD, they get misdiagnosed and may go years being treated for something that they don't have. Language also becomes an issue. Emotions, planning, judgment, the ability to sequence, doing things in order. Now think about how many steps it took you to get ready this morning. To brush your teeth, put on your makeup, comb your hair, take a shower, get in the car, get dressed. That's a lot of steps. And they lose the ability to be able to do things in order. Prioritizing, multitasking, and movement. Also, what falls in here is apathy. Looking like they don't care, maybe even saying they don't care about anything. You will hear it called frontotemporal disorder, frontotemporal disease, FTD, frontotemporal lobar degeneration, and you'll hear Pick's disease every once in a while, and we'll go over each of those more in depth. But I do want to just start, let's just look at it. This is neuroimaging and cognitive impairment. The first one on the left is a normal brain. We talk about lighting up our brain whenever we're doing things to light up our brain. We're studying, we're reading, we're learning something new, and those dendrites fire and we light up our brain. Look at that normal brain, how lit up it is. The one in the middle is somebody who has Alzheimer's disease, the most common type of dementia overall, but not in people under 60, as we now know. And look at FTD. Look what's going on in that brain, and especially look at the bottom picture, I think is very, very telling. Look how that brain up here in the frontal lobe has pulled back. And those black areas you're seeing, those are holes. That's where the brain has already failed and died. Now, this next slide, I know it is a little bit fuzzy, but it has got some fantastic information on it. And I encourage you, when you get these slides, to run this one off, because it does a great job comparing FTD to Alzheimer's disease. And I want us to look at each of these so that we understand the difference moving forward. Now, we know that 60 to 80% of all dementias is Alzheimer's disease. That's why it's the one that we hear about the most often. But we just heard that newest statistic that in under the age of 60, FTD is the most common. Look at the age of onset. We rarely see FTD in anybody over the age of 75. In fact, we usually see it before the age of 65, and we'll look at more specific numbers in a little bit. Early behavioral problems are very common with FTD, but they're unusual with Alzheimer's. Now, these are challenging behaviors or expressions. Socially inappropriate behaviors, and again, we're saying the word expressions, are really common, socially inappropriate, but they're not as common in Alzheimer's unless it is a severe case of Alzheimer's. Language problems earlier in the disease, and we're going to talk about the specific language problems that a person with the different types of FTD can have. I want us to skip down and go to mood in FTD. And this is how this disease can present. And I want you to be thinking about, if you don't already know, the things that they might get misdiagnosed with. So if somebody presents with marked irritability, they're starting to withdraw from social situations, or when they are in social situations, they're doing and saying things that are very inappropriate. They might even have some psychotic looking tendencies, extremely jealous, extremely paranoid. They may start to gorge on food. Think about, what does that sound like? And if this is a person younger than 60, they are going to get misdiagnosed with having what is called a mental illness. And the three things that they are most commonly misdiagnosed with, and it will run the gamut: schizophrenia, bipolar, major depressive disorder. And if it is a woman, which is not in women near as often as it is in men, many times they, because of the age, before the age of 60, they will try to say that it is something hormonal that they have going on. So let's look at some of those terms I mentioned earlier. And you may see these on different things, but now you'll know what they mean. When we have BVFTD, that stands for Behavioral Variant Frontotemporal Dementia. It's the most common frontotemporal disorder. About half of all the cases are BVFTD, and we're going to deep dive into each of these. You may also have heard the word Pick's disease. I mentioned it earlier, and this actually was the original name of frontotemporal dementia because it was named after Dr. Arnold Pick, who in 1892 described patients with these distinct symptoms. So you may have heard of a type of dementia called Lewy body dementia. This was originally Pick bodies. And there's a picture of what it looks like, Pick bodies. You may also see FTLD, frontotemporal lobar degeneration, or that frontotemporal disorders or frontotemporal degenerations or frontal lobe disorders. This is all referring to changes in behavior and thinking. It is not a single brain disease. Like I said earlier, FTD is a family of related neurodegenerative diseases. It is a form of dementia. Another place that I found some new statistics, because again, new statistics come out in August and in January for those of us in healthcare, is the Association for Frontotemporal Degeneration. FTD is now the most common dementia in people younger than 65. The other one said people younger than 60. And look at these ages. 60% of those that get diagnosed are between 45 years old and 64 years old. Now, there's not a day goes by that I do not teach students, families, or other healthcare professionals. And one of the questions that I will ask is, when you hear the word dementia, what age comes to mind? And the most common age that people say is 80s, 90s, 45 to 64 years old. Life expectancy is 7 to 13 years. However, we have to keep in mind it is different for everyone. It depends on other comorbidities. It is a progressive disorder like all the other dementias. And something unique to FTD is that in the earliest stages, they may just have one symptom. This is another reason it doesn't get diagnosed correctly early. And I said earlier, this disease can present with no memory loss. It's coming, but they may have a lot of other symptoms and not have any memory loss. And people who aren't informed or who don't work in the field of dementia may never think that's dementia. There's no cure, there's no treatment, there's nothing that slows or stops the progression of the disease like the other dementias. It is very difficult to pick up in the earliest stages because it moves so slowly. And most of the time, what we see first is personality changes. So again, we have someone between the ages of 45 and 60 who's having personality changes. One of the last things we're going to think is dementia. In fact, I've had families who thought their loved one was drinking, their loved one was doing they're going through a midlife crisis because they never stopped to think that it could be a type of dementia. We're going to talk about the genetics, but there's a strong family history. And the other thing to know is it is 4 times more common in men. We did find this great short video that does a very good job at explaining the disease that we're going to watch. I think it's 3 minutes. Again, keeping in mind that people often get misdiagnosed, or doctors, professionals will be thinking along the line of schizophrenia, bipolar, or major depressive disorder due to age and symptoms. But let's watch this short video.
Let's talk about frontotemporal dementia. It's a long term and a scary one, but it's important to understand what it really means. Let's break it down. Fronto and temporal refer to the parts of the brain affected by the disease, the frontal and temporal lobes. The frontal lobes are in charge of executive functions like planning, prioritizing, and multitasking. They also help you decide what's important in different social situations. For instance, it's your frontal lobes that enable you to follow directions in a recipe and to talk quietly in a library. The temporal lobes play a major role in language and emotions. They help you understand words and communicate. They also help you recognize objects and people and control your emotions and figure out what may be triggering them. Someone with damage to their temporal lobes may not understand that a hot stove is dangerous or why you're worried and upset when they try to touch it. The temporal lobes also manage memory storage. However, for most people living with frontotemporal dementia, or FTD for short, memory changes are not a major symptom. That's one of the many ways FTD is different from other common types of dementia, like Alzheimer's disease. Here's how else they compare. FTD usually affects younger adults. It is the most common form of dementia in people under the age of 60. Symptoms of FTD usually start in people aged 45 to 64, but may also occur later in life. Also, FTD is less common than Alzheimer's, and much less is known about it. It is frequently misdiagnosed as Alzheimer's, depression, or a psychiatric illness. On average, it takes 3.6 years to get an accurate diagnosis. Unfortunately, there is no cure for Alzheimer's or FTD, but some treatments are beginning to emerge. That's why it's so important to take part in clinical research if you can. When it comes to FTD, like everything, knowledge is power. It is critical to get the right diagnosis. This will help avoid potentially dangerous medications you don't need and empower you and your care partners to prepare for the future. Learn more about dementia and get the support you need by calling 858-492-4400 or visiting alzsd.org.
That is a great way to summarize what we've talked about already. One of the things that I wanted to point out from the video was that she made the comment that the average time to get a diagnosis is over 3 years. And that in the meantime, we're being treated many, many times for a psychiatric illness. And we may be on psychotropic meds. Simply because even the doctors don't know what to look for. So let's go through and start looking at symptoms of FTD. Now, keep in mind, this is going to be different for everybody because it depends on which part of the brain is affected. That's going to be what symptoms show up. What part of the brain is affected and what part of the brain is affected first, and then what order this progresses in. But some of the things that you might see that in FTD are common are what we're going to look at on the next 3 slides. We've mentioned socially inappropriate behaviors. So something like laughing out loud at a funeral, difficulty picking up or reading social signs that we all have learned from the time that we were very young, having a really, really hard time making decisions. Now, this one that says engaging in purposeless activities. Here's an example. This was one of my clients one time when I worked for the Alzheimer's Association. It almost looked like OCD, obsessive compulsive disorder, and that is really common with FTD for folks to have what could look like OCD. And this particular person became obsessed with sorting all of his nuts and bolts into baby food jars. And I swear he had millions of them, at least thousands, because he had a shop. Now, was there anything wrong with that? Absolutely not. There wasn't anything wrong with it. It was harmless. It was keeping him really, really busy, but he was obsessed with it to the point that he didn't want to eat. He didn't want to sleep. He had to get this finished. So it can look a little bit more like that. Trouble linking words together, some motor difficulties, and we can see some stiffness and some balance issues. So there might be that misdiagnosis of even Parkinson's, or thinking along the lines of a Parkinson's syndrome. Struggling not only to speak, but to understand words. And we're going to look closer at what's going on in those language centers that we mentioned earlier. Now look at this about writing. They might not be able to do something like write the word all. You say all, A-L-L, but they can write the word alligator, which is a much longer, more complicated word. They can't do the small word, but they can do the longer word. Some other things we might see. Sexual aggressiveness, vulgar language, loss of inhibition, using racial slurs, curse words, and sex talk because of the parts of the brain that are damaged. They're not doing it to give us a hard time. They're doing it because they're having a hard time. And then for them to have the apathy and maybe even say, I don't care. And they have a look, a flat affect of, I don't care about anything, a flat facial expression. And keep in mind that most people younger than 60 and they're having these type of symptoms, this isn't sounding like the dementia that most people know, because we haven't mentioned memory loss yet. They may even have symptoms of what looks like hypochondria. Then we may start to see some memory loss, especially to those that are closest to the person. We mentioned earlier about having problems with sequencing. That all goes together with what's called executive functioning, being able to plan. We watch the weather. We see it's going to be 105 degrees today. I'm not putting on a turtleneck. We might even could say to somebody with FTD, because we're trying to be reasonable and rational, and they don't have the ability to be reasonable or rational. We mentioned earlier about the compulsive behaviors, and 80% of people who have FTD will go through a phase of compulsive eating or gorging, and it's usually on very, very starchy or high carbs. Impulse control, and then again, that apathy, that lack of interest in anything. A few more symptoms that we might see, and this was mentioned in the video, is the inability to recognize danger. And in the video, they used the stove and the person touching or putting the hand on the stove. Think about what's going on in the brain for something that we've known from the time that we were a child, that they no longer realize that that's hot or that that's sharp, or that this is a dangerous situation. Lack of self-awareness also. And then we mentioned earlier things that happen physically with gait disorders, clumsiness, or even a tremor. Now we talked about causes, and 40% of the time we find genetics with a gene mutation. And this is why in the video, and as you read more about FTD, they are begging people to be in trials and in studies as they're learning more about FTD. Alzheimer's disease is the one that gets talked about all the time, and they've pushed studies. Parkinson's now, because of Michael J. Fox being another family where they have just been very public about the disease. There's lots of research going on, lots of study. And now the FTD organizations are pushing that people get into trials and studies, and I'll give you information about how to do that in the last slide. But for more information about the genetics, the very last bullet point there, I've got a website that you can go to look at the specifics about genetics and FTD. Now, I did want us to break down and look at, we talked about the FTD is its own umbrella, like dementia is an umbrella. So we're going to look at the different types that are listed here. That BV FTD, the progressive non-fluent aphasia, and the semantic dementia. And there's some statistics on there as well. Each of these, when we really start breaking down FTD and studying it, could have its own umbrella. There's the FTD, and then under each of these three, we could also have an umbrella of diseases that fall into the dementia category. Now, what's interesting about the one on the far right called semantic dementia, it's characterized by the inability to match certain words with their images or meaning. Hear that again. They're not able to match words with their images or meaning. They know the word, but they can't necessarily match it to the meaning or to the image. Most people who have this, though, retain the ability to speak quite fluently. And they also can tend to remember from day to day. This is a subtype, and we find it many times being a subtype of another type of dementia called primary progressive aphasia. This is another graphic that really breaks down and shows us that umbrella, the frontotemporal dementia, but this one adds those words, primary progressive aphasia, a progressive disorder of language. And then it breaks it on down as to what comes underneath that umbrella. And we'll look at each of these a little bit closer. But you notice what's changing there is we're having lots of changes with language. In all of the dementias, keep in mind, this is with all of us, there's a right side language and a left side language. And in most of the dementias, left language leaves first. Left language leaves first. And that's our day-to-day language. Now, this is all the dementias. It's our nouns. It's our proper nouns. It's our day-to-day table, chair, boy, girl, aunt, uncle, son, daughter. But that right side, that language is the rhythmic language. And that right rhythm remains for a very long time in many people. So that means music, rhythm, music, poetry, prayer, ABC, 1, 2, 3. Things that have a pattern, a beat, or a rhythm will stay. But unfortunately, and again, this is all dementias, unfortunately, sex talk, racial slurs, and curse words store on the right because they're not day-to-day language. They didn't store on the left when we first heard those words. When we were little children, they stored on the right and they remain. So again, this is going to break it down. The progressive behavior with the personality decline, there's the types that we might see. The progressive language decline and the different types, and the progressive motor decline. And we're going to break each of those down. This is another slide that's talking a little bit more about the symptoms we may see first. In the BBFTD, we may see those personality, behaviors, emotions, and judgment changes first. In primary progressive aphasia, we tend to see a progressive language decline first. And the majority of people with PPA or primary progressive aphasia are 45 to 65. The corticobasal syndrome we tend to see more of the progressive motor decline first. So let's look a little more specifically at the behavioral variant frontotemporal dementia and what it looks like. Again, this is the most common of the FTDs. It's responsible for about half of all cases. It can develop as early as somebody's 20s, in their 20s. It has happened. And it can develop as late as a person's 80s. It just isn't that common. We've already mentioned that sometimes you may hear the word Pick's disease, frontotemporal dementia, or just FTD. And with this one, the personality changes, the behavioral changes, and the judgment changes first. Notice that on this one, memory is at the bottom. Memory changes is at the bottom.
Holly accidentally muted you.
Thank you. The next one, the primary progressive aphasia. And this one we're starting to hear more and more about. There have been some celebrities that have come out and who have talked about this. I know if you're familiar with Brad Paisley and Kimberly Williams Paisley, her mother had this, and they were out front and talked about it throughout the course of her disease. But even under the primary progressive aphasia, it has its own umbrella, and there's 3 types of it that are all listed here also. We've got the semantic PPA, which is where they very slowly lose the ability to understand those words. The progressive non-fluent aphasia, where more and more trouble producing speech themselves. And then that logopenic, I may be saying that right, where they have trouble finding words, but they can understand words. And then let's look at these. Corticobasal syndrome, or CBS, and progressive supranuclear palsy, PSP. All of these, again, fall under that FTD umbrella. But look how this presents, and think about what they are likely going to get misdiagnosed with. Because with the PSP, it causes problems with balance and walking. So if somebody's younger than the age of 60 and they present at the doctor with unexplained falls, a flat expression, and body stiffness, that sounds like Parkinson's all day long. And so the doctors are going to have to rule that out. They may even start them on some medication. That's what the video mentioned, is that our loved one may go years being misdiagnosed and on medications that could possibly be doing harm rather than good, because nobody stopped to think that it could possibly be FTD. This CBS, or the corticobasal syndrome, causes a progressive loss of the ability to control movement, and it usually is around the age of 60. And it usually begins with the inability to use the hands or the arms. Now, again, if we go out and ask the general public, tell me everything you know about dementia, I always get 3 answers. They don't remember, they forget, and they have memory loss. And those 3 are all the same thing. But to have somebody presenting with the inability to control movement or to use their hands and arms, that doesn't sound like dementia. And if we're seeing a doctor, if maybe we're even seeing our primary care physician who doesn't specialize in dementia, then our loved one may get misdiagnosed. Now, there are 2 other types of FTD that fall under, we kind of put it under an other motor decline. And these are fairly new. It's called a mixed dementia because they actually end up with what is 2 or more dementias. But let's look at this first one because you've heard me mentioning Parkinson's. A person can be diagnosed with frontotemporal dementia with Parkinsonism. And a person can be diagnosed with frontotemporal dementia with ALS, or that's commonly known as Lou Gehrig's disease. It's when they have a combination of both diseases. So it is possible. We actually know now that a person can have, in fact, the most common type of dementia in general is Alzheimer's disease. And number 2 now is mixed dementia, which means that they have more than one type of dementia. So how do we get the diagnosis? We have got to find an expert, that's for sure. And we are likely going to end up at the neurologist, possibly the psychiatrist or a psychologist during neurological exams. Definitely going to have brain scans. We saw earlier on the scan that we looked at, you can see FTD because in frontotemporal dementia, the brain is starting to, hold on just a minute. The brain is actually starting to, hold on just a second. The brain is starting to atrophy from this frontal area. We could see it. We also have MRIs where you can look at it and you can see it. You can see that that brain is beginning to atrophy specific to the frontal lobe areas. So MRIs, PET scans, there's a scan called a SPECT scan. They're going to do a complete record of their symptoms. They're going to ask about family history because we saw earlier about 40% of the time it's genetic. Blood test, physical exam to rule out anything else that might possibly be mimicking this. Genetic testing, if appropriate. And then we mentioned the neuropsych. Treatment and management. So we talked a little bit earlier that what we can do for FTD, what we can do for all the dementias is to manage the symptoms. Manage the symptoms. Because we know there is not a treatment. Even with these medications that are called memory meds, what we're doing is we are treating symptoms. We're treating symptoms. So we've got to develop a support team. And on that support team, we are not just going to have doctors and nurses. We're going to have physical therapists, occupational therapists, speech therapists. Hopefully we can get in a music therapy. We're going to get in a support team. Our pharmacist is going to be part of our support team. As loved ones and as professionals, we're going to continue to educate ourselves about this disease. We're going to learn early on, hopefully, not to argue or try to reason with somebody with FTD. Now, this is all dementias. We're going to limit choices. We're going to keep a routine. And we have to keep in mind that all of those behaviors or challenging expressions have a meaning. They are communicating in one way or another. Now, I found this card that I took a screenshot of and I shared it. We have cards here at the West Center that people can pick up to take with them to restaurants or when they're out in public that says something similar to this, but this is specific to frontotemporal. And you can actually go to the website of the Association for Frontotemporal Degeneration and you can run these off, you can order them, and look what it says. Please pardon my language or behavior. I have a brain disease called frontotemporal degeneration. Thank you for your patience. What a great thing to have at the restaurant. And you can just set it right there on the edge of the table and point to it and let the waiter see that. What a great thing to have with you in the store. What a good thing to have with you in the doctor's office for people who are sitting in the waiting room with you. I even had a family go so far as creating their own personal card, and the daughter had it made about her dad. And it said something very similar. Please pardon my dad. He has, she listed the disease that he has. Thank you for your patience. It goes a long way, but you can get those. And it has the website there, and it also has a helpline, and I'll give you more resources at the end. Again, on treatment and management, validation therapy is probably one of the very best things that we can do. And it takes a whole lot from us as the caregiver to learn how to validate somebody's feelings, especially if to us it seems irrational. So we have to give ourselves that permission to take that time out. We have to give ourselves permission to use respite or to use an adult day program. Or sometimes we get to the point that we have to give ourselves permission to place our loved one. Because there's safety is what it comes down to with placement. And we've got to remember there's two types of safety. There's physical safety and there's emotional safety. And it's not just for the person with dementia, but it's for the caregiver as well. For someone with FTD, it is very important to keep a schedule, to keep down the distractions and modify the environment. Again, medications are available to treat certain behavioral or expressions. Antidepressants are very commonly used to help treat social disinhibition and impulsive behavior. And some people do end up taking some low doses of antipsychotic medications during that phase. We know with all dementias, these are phases that they're going in and out of. Now, when we're in the middle of one of those challenging phases, it can seem like it's never going to end. But it does. They all do. And they'll move into the next phase. Language is going to continue to decline. That's part of all of the dementias. But early on, some of the things that we might do is to start using a communication notebook, really starting to learn to use gestures and body language, drawings. You can even go on Amazon and you can buy, they look like they're about the size of I've just lost my word. The dinner, placemat. And they can point to words and pictures, or you can create your own. A lot of folks will do that. They'll create their own laminated. We learn to speak slowly, a little more clear, and to use simple sentences. Leave out the adjectives and the adverbs and bring those sentences down to 3 to 5 words. Working with a speech pathologist, they will go in and out of PT, OT, and ST throughout the course of the disease. Take full advantage of that. And if the doctor doesn't recommend it, ask for it. A referral to physical therapy, occupational therapy, speech therapy throughout the course of the disease. Are they going to cure the disease? No, they aren't. But are they going to bring comfort? Yes, they are. Therapy brings comfort. Notice on the second bullet point, because again, we want to find out specifically what type of disease it is, because for some people that have the corticobasal syndrome, Parkinson's disease medicines might actually help improve their movement. Going into physical and occupational therapy may help for a while. So finding out the type of disease that they have can be really important as far as treatment terms goes. Now notice on that last bullet point, this was that very specific FTD ALS, where they have both diseases. They tend to decline rather quickly. In fact, it's usually within 3 years that they'll succumb to the disease. But again, with each of the FTDs, and this is with all dementias, with all of the 130 plus dementias, we want to make sure that they're going in and out of physical therapy, occupational therapy, and speech therapy. Now, when they have these compulsive behaviors or expressions, one of the things that we want to do, if we will start keeping a journal as caregivers, it's important to keep a journal. We want to see if we can figure out a trigger, because sometimes it will be something that you never would have thought that could trigger a challenging expression. So what was on TV? What was the weather like outside? What happened right before the incident? And if you keep it written down, you may figure out the pattern. Try to maintain that routine. Try to have some type of daily physical activity as an outlet for them. But then we want to validate their feelings, even if that feeling is, you're the one that took all my money. How do I validate that? Okay. Okay just means I heard what you said. I'm calling the bank. I'm going to get it fixed right now. And I get on the phone and I place a call to the bank. I'm not calling the bank. Therapeutic stories. Some people call them lies. We call them therapeutic stories. And then I'm going to distract them away from this. And the 4 things we use for distraction are food, music, animals, and children. Food, music, animals, and children can just do wonders. If you don't have real animals and real children, that's what YouTube's for. Type in children laughing, and you will sit and have the most fun watching videos of children playing and laughing, or baby animals falling down. That's another fun one. We also want to really look at the environment. There's a statistic that says that about 80% of the time, if somebody has a compulsive or a challenging behavior or expression, it's because of our approach or the environment. Now, we wouldn't do it on purpose, but we didn't know what we didn't know. So we're going to minimize the noise and the stimulation, reduce the clutter, and simplify social situations. We don't want to set them up for failure. Now, I am excited about this term because those of you who have been following us for a while know that we are all about using hospice and using hospice as soon as possible, taking advantage of that. It doesn't mean that the person is imminent. It is an added source of care. But there's a new term out there, and it is neuropalliative care. I love it. Neuropalliative care is a new and growing field within neurology. It focuses on improving the quality of life of patients with serious neurological illnesses. It can be started at any time during the diagnosis, and it changes as the disease progresses. It eventually will become hospice care when they get down to the last 6 months of their life. But palliative care is comfort care while still receiving treatments. So you can be on palliative care and still be going to therapy. And look what it focuses on: relieving physical, emotional, and spiritual distress. That's what palliative and hospice care is about. But now we've got this specialized field called neuropalliative care. Our medical director has said for the 30 years that she's been here, we are palliative care here at the West Center. It's what we do. We provide comfort. We're not curing anybody, but we provide comfort and quality of life. Here's those resources that I was telling you about, and this has some good information. If you have a loved one with FTD, please go to the website at the Association for Frontotemporal Degeneration. There is tons of information, lots of education, and please hear this, there are grants available. Grant means you don't have to pay it back. Grants for respite for your loved one. You can use it for travel. You can use it to do things for quality of life. I had someone tell me they used it to do some bucket list type things. All through the AFTD. They also provide support groups. I've given you their phone number and their email. And that shouldn't say email, that second one should just say that's their website. Also, the National Institute on Aging has some really good information. I've given you the site there. And there is FTD Disorders Registry, which provides information. And I told you I'd tell you about some research. There's some research opportunities through the FTD Registry. People who have been diagnosed with FTD do qualify for Social Security disability because they typically are younger than 65. And so you contact Social Security and the phone number is there for that as well. Perfect timing. We are right at the end of the program. I appreciate you being here today. We will send out the slides. Let me stop sharing. And the recording of the program. Jamie, was there anything to add?
Just a quick reminder, when we send out the follow-up email with the slides and the recording, then the link to the evaluation, please everybody complete the evaluation. And if you want to CE credit, you must complete the evaluation. And if you have any questions, please feel free to respond to either Holly and I.
And on that very last slide, there is our email and our phone number is on there. So please reach out to us and we might not get back with you within 5 minutes, but we will get back with you at some point. So please be patient with that. Thank you so much for being here today and spending an hour with us. And hopefully we will see you on some more of our programs. Thank you. Bye-bye.